Bhandari. She is a PGY2 ambulatory care pharmacy resident from the University of Illinois, Chicago, who will be presenting to us on effects of social deprivation factors on prescribing practices for anti-hyperglycemic therapy.
Thank you for that introduction, and then let me share my presentation screen. Alrighty, so now that you can see my presentation, yes, my name is Deepali Bhandari, and today I'll be speaking about my project or research project titled Effects of Social Deprivation Factors on Prescribing Practices for Anti-Hyperglycemic Therapy. So I am a PGY2 ambulatory care resident at the University of Illinois, Chicago, where this research is being conducted. And I would like to acknowledge my mentors throughout this process, my primary mentor being Dr. Liz Van Drill, who is here today, so thank you for that. And then relevant financial disclosures are listed on the screen. For the learning objective, we have one that at the conclusion of this presentation, participants will be able to explain how the social deprivation index may be used to quantify socioeconomic variation in health outcomes. So to provide some background, in recent years, there have been updated guidelines from the American Diabetes Association, or the ADA, that recommend the use of newer anti-hyperglycemic or glucose-lowering agents to treat type 2 diabetes. Not only are there a variety of new agents, but also the way that we treat diabetes has changed with time, going from metformin being first line to now doing more comorbidity-based treatment algorithm. We also note that clinical inertia and the intensification of glucose-lowering therapy continues to remain high, and racial, ethnic, and socioeconomic disparities do exist when it comes to optimizing diabetes care. So what can we really do about this? Well, there are tools available to us, one of them being the Social Deprivation Index, which I'll refer to as SDI. It is a composite measure of area-level deprivation based on demographic characteristics and can be used to quantify socioeconomic variation in health outcomes. There are a few categories that the SDI looks at, such as the percent of people living in poverty, having less than 12 years of education, being in a single parent household, percent being in rented housing units, an overcrowded housing unit, a household without a vehicle, and the percent of non-employed adults under the age of 65. And so what I want you to understand with the SDI is that a higher SDI value suggests a higher level of deprivation, and the score ranges from 1 to 100 and can be associated with the zip code or the postal code that someone is residing in. So the study objective for my study is that the use of local data to identify the effect of SDI on prescribing practices can actually allow for the development of effective interventions to reduce health disparities. And the hypothesis is that there is an association between the time to intensification of glucose-lowering therapy and socioeconomic deprivation factors for persons with type 2 diabetes who are not meeting glycemic targets. This is a study which looked at a primary outcome of the rate of glucose-lowering therapy intensification, meaning a time to event, after an A1C was identified as being above an age-specified A1C target. And so the targets were defined as less than 7% for a person aged less than 65 years old. If someone was 65 years or older, we set the A1C target at a goal of less than 8%. And then we looked at covariates such as patient characteristics listed here and prescriber characteristics as well, because of course we are looking at prescribing practices in this project. For the design, I want to point out this is not a chart review. So this is a single center retrospective cohort study conducted at UIH, and it looked at a population of individuals with type 2 diabetes receiving outpatient care here. And then the timeline was initially identified as January 2010 up until September 30th, 2023. And patients were entered into the cohort at time 0, which would be the time that an individual's A1C was above the age-specified goal. And then they were followed until the event occurred, the event being when the glucose-lowering therapy was intensified. I went ahead and made a visual as well to help understand how we're putting this together and following these individuals over time. So the initial assessment window was to allow for exclusion criteria. So this was 18 months prior to when the A1C was identified as above goal or time zero. Each person or each individual in this data collection is going to have a different cohort entry date, or they could have a different cohort entry date because it's based on when that A1C was identified as above goal. So looking 18 months prior to look at inclusion, exclusion criteria, also identify the patient's medication list, then collecting the patient baseline characteristics at time zero, which included the postal code to allow us to find the social deprivation index, and then moving forward in time up to 18 months max to identify if the event actually occurred. The event, again, being glucose-lowering therapy intensification. So we have some preliminary data. This project is still in the works, but today I can speak to this initial cohort that we're looking at. So this is a shortened amount of time looking from September 12th, 2020 to September 30th, 2023. The reason for this is that this is specifically looking at EPIC data. So this is when our institution transitioned from Cerner over to EPIC. And then the inclusion criteria is listed here as individuals who are at least 18 years of age. They had to meet all of the following criteria. So an A1C of at least 6.5%, having a documented diagnosis of type 2 diabetes, which was identified as a diagnosis attached to an encounter, and then having antihyperglycemic agents included in the current medication list. Exclusion criteria was the age less than 18 years, having type 1 diabetes or a history of gestational diabetes attached to any encounter, not receiving primary care services at UIH, having hemoglobinopathies, which may produce inaccurate A1C values, such as anemias or thalassemias, or sickle cell disease. And I want to point out here, and this is the initial cohort, so later on, this criteria would be broadened to allow for more data collection. So to follow the study screening, what I said was inclusion criteria, but there's a step method to it as well. So first we looked at individuals with an A1C value of at least a 6.5%. Then from that group of individuals, we moved forward trying to identify, is there a type 2 diabetes attached to any of the encounters? Type 2 diabetes diagnosis attached to any of the encounters. And then from there, we looked for an active order for glucose lowering agents. When it comes to data collection, the covariates we have for now are from the patient baseline characteristics, the age in years, the sex identified as male or female, the zip code or the postal code, which allows us to calculate the social deprivation index. For prescriber baseline characteristics, so this is the prescriber who actually put in the new medication order if it was identified as glucose lowering intensification. And so these characteristics we do have available in a database, but have not quite been applied as covariates yet. But there's age, sex, race and ethnicity, the specialty, the clinic location, the status, whether they're a resident or an attending, and then the degree and license. So we can look at the prescribing or the ordering prescriber in EPIC to identify if it's someone with an MD, an APRN, a PA, or even a PharmD. The primary outcome was looking at the time of the event would be the date and the time that it took for the A1C, the time for the event to occur after the A1C level was above goal. And then from there, we can also see the medication order itself to identify the class of medication and the dose of the medication as well. For statistical analysis, we have descriptive stats listed here. We ran a Cox proportional hazards model in the program R, and this allows us to explore the relationship between SDI and time to intensification of glucose lowering therapy. And then we'll also look at the relationship between patient and prescriber characteristics and that time to event as well. So we were able to find over 10,000 individuals met criteria. From there, 4,285 actually had an A1C above the age-specified goal. And then the event, meaning glucose lowering therapy intensification, occurred in 3,593, or about 84% of that cohort. Looking at some of the baseline characteristics, we can see here that about 56 to 57% being female. When it comes to age, most of the patients or most of the individuals were at an age of less than 65, so 83%. And then I went ahead and listed the mean age, the mean SDI, and mean A1C as well. You can see the average person in this cohort was about 54 years old, had a social deprivation index around 83 to 84, but a big variety there in the plus or minus 21, and then a mean A1C of 9.4%. Some additional baseline characteristics: most of these patients were identified as Black, non-Latinx, and then from there, Hispanic Latinx. And then now for the preliminary results. So we can see here, I went ahead and bolded the primary outcome being the SDI, the regression coefficient, and then the hazard ratio, and the 95% confidence interval, and the p-value. So we actually found no statistically significant difference in the primary outcome, which we can see from that hazard ratio of 1 and confidence interval from 1 to 1, and the p-value being above 0.05. And so there, we identified no association between time to intensification of glucose-lowering therapy and SDI for persons with type 2 diabetes not meeting glycemic targets in this particular cohort. The nice thing is we can also identify some other data like the time to event curve, and can see that most of the intensification, if it was to occur, actually occurred within the first 30 days. So this is a survival curve, but we actually want the event to happen. So although we're seeing this as a survival curve, it's actually a good thing that the glucose lowering therapy was adjusted. And then just to briefly touch on some limitations, again, this was not a chart review, so dose adjustments and contraindications could be documented in notes, but not through med orders. The exclusion criteria did remove a large chunk of the population if they had any diagnosis of gestational diabetes or type 1 diabetes in their chart. We're unable to account for non-adherence, but of course we are looking at prescribing practices, not necessarily patient adherence. And then this is a narrow patient criteria. So there are plans for the larger cohort to be identified for expansion of this project, and looking all the way back to 2010 to look at Cerner data and also look at interclinic variability as well. And then there will be further analysis of all the covariates I mentioned before, looking at additional patient and prescriber characteristics. So moving forward, kind of what I was touching at earlier, we'll use broader inclusion criteria for a larger cohort size, perform data collection and analysis on that larger cohort, and then move forward in identifying the effects of SDI and those covariates on prescribing practices across our health system. I had an assessment question, but for the sake of time, I will not be asking this, but it basically touches on the different areas of the social deprivation index, which was earlier in my slideshow. I have a list of references here, and I am now open for any questions you may have.
All right, thank you so much for your presentation. So keeping an eye on QA, thus far we do not have any questions that popped up during the presentation, but we are opening the floor in case any of our attendees would like to ask a question.
Hi there, I have a question for the presenter. So thank you so much for your presentation. We had a resident in our program who was considering looking into area deprivation index as part of their research project, but they ran into the issue that the system uses the long zip code, not just the abbreviated 6-digit zip code. And so they weren't having that information in the electronic health record. Did you run into that issue at all during your project? And if so, how did you overcome that?
Yeah, thank you so much for that question. So you mentioned the area deprivation index, which is ADI, and my group had initially thought to use that as well. So that one, I think, looks at additional criteria outside of what the SDI looks at. So although the SDI does not account for quite as much as the ADI does, the nice thing about SDI is you only need the 6-digit zip code, because you're right, the other ADI did need a longer zip code, and we realized we wouldn't be able to pull that easily from that chart.
Oh, wonderful. Thank you so much. That's definitely something we'll have to look into that.
Yeah, thank you.
Sorry, one more question. I apologize if I missed this, but did you guys select their patients' like health insurance status? Because I'd be curious to know like if someone did have it in insurance versus say like Medicaid for the coverage of medications, if that changed it.
Yeah, and no worries. We did collect insurance status. It was in the huge charts that I had. I didn't say it out loud. That's a really good question. So we are able to identify both through Cerner and Epic, the primary payer. Epic is also able to do the secondary payer, but we did run into an issue where Cerner could not pull secondary payer. So the plan moving forward is to look at primary payer for all the patients and the larger cohort. So it's definitely something you can think about if you do a project like this in the future.
All right, wonderful questions. Are there any other questions from the attendees? Oh, I think I see a hand raised. Great. So I believe the hand was kind of put down. Last minute, any questions for Deepali before we move on to our next presenter? All right, I am hearing some silence. So with that, we'll go ahead and move on to our next presenter, who we have Kayla Godfrey. She is a PGY2 ambulatory care resident from the University of Iowa Hospitals and Clinics, who will be presenting research focusing on evaluating penicillin allergy in obstetric patients to optimize guideline-directed Group B Streptococcus prophylaxis.
Thank you, Yvette. I will share my screen here. Okay, excellent. So as mentioned, I'll be talking about the evaluation of penicillin allergy in obstetric patients to optimize guideline-directed Group B strep prophylaxis. I have no financial disclosures. And starting out with a little background, approximately 10% of patients carry a label for beta-lactam allergy. And after evaluation by an allergist, up to 98% of these individuals are found to be beta-lactam tolerant. This is generally due to a few different reasons. One being patients not having a true allergic reaction, patients having a false drug allergy label placed in their chart, or because they are no longer sensitive to penicillin antibiotics. So what we know is that about 50% of patients lose sensitivity after 5 years, and after 10 years, up to 80% of patients lose sensitivity. So why does this matter? Ultimately, a penicillin allergy label can lead to increased use of second-line antimicrobial agents that can sometimes be broader in coverage, less efficacious, have more side effects, and lead to antibiotic resistance. When we're looking at our obstetric population, we know that about 1 in 4 pregnant women carry Group B Streptococcus or GBS. Screening is recommended for all pregnant individuals between 35 and 37 weeks of pregnancy. And if they do test positive, they will then receive IV antibiotics during labor to prevent early onset GBS in newborns. As you can see here, the first line treatment recommendation is penicillin G, so one of our penicillin antibiotics, with alternatives being cefazolin, clindamycin, and vancomycin. In order to identify these patients, our obstetric team, along with our allergy team, which includes a pharmacist, and our antimicrobial stewardship team, came together to create this best practice advisory, or BPA, shown on the screen. As you can see here, it identifies patients with a penicillin allergy, and specifically on obstetric patients. The obstetric staff then has the opportunity to either order a consult to drug allergy clinic or decline the order and give an acknowledgement reason. For a little bit more in the workflow, patients will be seen at their obstetric visit. If they have a penicillin allergy present in their chart, the BPA you just saw fires. And then the obstetric staff can determine if the patient is a good candidate for drug allergy evaluation. The consult can then be placed or declined. And if it's placed, then the patient can be seen in the drug allergy clinic where their drug allergy is evaluated. A thorough history is taken about the drug allergy reaction, what it was to, when it happened, and how long ago it was. And then it is determined whether they are eligible to do penicillin skin testing and or a direct oral challenge where they actually take a dose of a penicillin antibiotic. If these are negative or they have no reaction, we can then remove the allergy and they are cleared to use guideline-directed therapy for GBS prophylaxis. So the purpose of this study was to determine the effectiveness of implementing this BPA in identifying true beta-lactam allergies and increasing the use of guideline-recommended antibiotic prophylaxis for GBS. Our objectives were, 1, to identify how many BPA identified patients underwent evaluation in the drug allergy clinic, to determine the percentage of patients evaluated that were able to have their penicillin allergy delabeled, and to investigate the use of guideline-directed therapy for GBS prophylaxis during delivery at our institution. This was a single-center retrospective IRB-approved chart review. The BPA began firing in 7 obstetric clinics in our institution on June 1st, 2021. On June 30th, 2023, we then pulled the data of all the BPAs that had been fired, and we collected on all of these patients, including their delivery information all the way up to a delivery date of 11/1/23. Looking at our demographic data, split into our 299 patients that we saw in drug allergy clinic and 429 not seen, we can see amoxicillin and penicillin were the most prominent drug allergies listed. I will point out here, a pretty significant number of patients had an unknown penicillin derivative labeled, especially in those not seen in drug allergy clinic. The reason for this is those that were not seen in clinic, we went off of their EMR recorded penicillin allergy, and oftentimes this was just a label of penicillins or unknown penicillin. And we were unable to ask the patients what their true allergy was since they weren't being seen in clinic. As far as the most common reaction, we saw the most hives and rash. And I also want to point out anaphylaxis here. It appears that 4 that were seen in clinic had supposed anaphylaxis and 17 in the not seen in clinic group. This just leans back on that same theory where we're just going off of EMR reported allergies, and oftentimes these are not accurate. We saw that frequently in those that were seen in drug allergy clinic where their label was actually different than what we determined once we were able to get a history and discussion with the patient. This looks at some demographic information for the 299 patients that we did see in clinic. You can see they were primarily seen later on in pregnancy, and reaction was most commonly occurred under the age of 10 and over 10 years ago. So over 80% of patients had this reaction happen greater than 10 years ago. You can see time and antibiotic varied, oftentimes unknown, especially with our childhood allergies. And then we also looked at our PenFast score. This is a score designed to help risk stratify patients' drug allergies based on a few different factors such as year since reaction, the type of reaction that they had, and if treatment was required. So you can see the majority of our patients fell in that low risk range, meaning they had about a 5% chance of a positive penicillin allergy test. When we look at the type of testing that was completed in the patient seen in drug allergy clinic, we see that 53.2% underwent an oral challenge only. This is due to many of the patients having less severe allergic reactions or having a reaction over 5 years ago. And based on some guidance that we have now, they support just doing an oral challenge instead of skin testing first. For patients that had a preference to do skin testing first or had more severe allergic reactions, we did do skin testing followed by an oral challenge. There were some patients that only underwent penicillin skin testing, most commonly either due to a positive reaction or wanting to defer due to time in clinic. And then those that did not undergo, we had 10.7% of patients that didn't undergo either. The majority of these patients did not undergo testing due to the fact that we could rule out their allergy with their history. Oftentimes seeing patients report yeast infection, nausea, vomiting, diarrhea, or possibly having a penicillin allergy since their kind of initial label was placed. Overall, what we saw was 97.2% had a negative penicillin skin test and 98.8% tolerated the oral challenge. Looking into the allergy status on these patients' charts after drug allergy clinic evaluation, we see 270 patients, or 90.3%, were able to be delabeled. The remaining 29, or 9.7% of patients, still held a drug allergy label. You can see 3 actually had a positive penicillin skin test. 3 had a reaction to their oral challenge. 2 actually requested for their allergy to stay on their chart despite negative testing. So we just notated that the negative testing had occurred, but left it on their chart for them. 5 had a possible type 4 reaction. So that would not be tested for in our drug allergy testing since it is a delayed reaction. And then 16 declined testing or deferred testing until later on. Looking at our known antibiotic use for GBS prophylaxis during delivery, we had 101 patients that we were able to identify antibiotic use for GBS. As you can see here, 48 patients that were seen in clinic. Of those, 87.5% of patients were able to use penicillin G. In comparison of those not seen in clinic, only 24.5% got penicillin G, and this was statistically significant. I'll also point out, of those not seen in clinic, a good portion at 54.7% did receive cefazolin. So this is due to some new guidance that we have showing that the cross-reactivity between cefazolin and penicillin antibiotics is very low. So we did have a notice go out to our surgeons during our study period that kind of indicated that they are able to use cefazolin even with a penicillin allergy label. So we definitely saw the results of that here. And the good news is we didn't have any mothers with allergic reactions or anything to cefazolin, even, if they had a penicillin allergy on there. So kind of in conclusion here, the utilization of our BPA led to many obstetric patients being seen in drug allergy clinic for the evaluation of their drug allergy. And over 90% of patients were found to be penicillin tolerant after evaluation. This study resulted in the use of more first-line treatment for GBS prophylaxis in obstetric patients. And penicillin G was given more often in patients that had their drug allergy delabeled after clinic evaluation than those that were not seen. To touch on some limitations, this was a single center retrospective chart review. Additionally, as mentioned before, it relied on some EMR documented allergy and reaction information for those not seen in clinic. And then I kind of mentioned those parallel changes in practice due to some of our antimicrobial stewardship efforts. So that notice that had went out to surgeons in September of 2021 that did encourage them to use cefazolin even in those with a penicillin allergy. This is great because it did decrease the use of some of those broader spectrum agents like vancomycin. However, it may also have decreased the obstetrician's desire to actually place the drug allergy consult, knowing that cefazolin was kind of an alternative for these patients. And then lastly, we do have a lot of frequent one-time obstetric referrals for complex patients at our institution because we are the largest academic institution in the state. So these patients often travel from all over the state and may not come back for more visits. So this can be challenging for them, even if they do get consulted, for them to actually come back and be seen. Some future directions of this study, one would be to identify whether more drug allergy time should be allotted to obstetric patients for drug allergy delabeling. We currently have 1 day a week where we have a pharmacist physician team that sees a lot of these patients. And then we also have kind of expanded in kind of the second year of this study to more of the other providers being able to see these patients, but it would be great to have more allotted time for this specific population. And then investigating the utilization of clindamycin, vancomycin, and cefazolin in this patient population prior to and after the study period. Implementing a method for removing patients' drug allergies from outside EMRs and pharmacy dispensing systems other than just giving them wallet cards. So when patients are delabeled, we give them a wallet card that states that they were drug allergy tested and are cleared to use penicillin antibiotics. However, this doesn't always get disseminated to other hospital systems or other pharmacies. So coming up with a method that enables us to communicate with them. And then lastly, we would like to expand this BPA to some of our family medicine clinics as they also see obstetric patients. Thank you. And at this time, I will take any questions anyone has.
All right, and thank you very much for your presentation. No questions have come up in the Q&A thus far, but again, we'll open up the forum to any questions that people would like to ask directly. I guess perhaps I will be one of the askers. So for Kayla, you mentioned that for the BPA, there's the option whether or not to go forward with the consult or decline the consult. By any chance, were you able to find any particular reasons why a clinician might choose to decline the consult? I think you mentioned perhaps the antimicrobial stewardship efforts that have been one of the reasons. Any other reasons that may have come up in your research?
Yeah, that's a great question. That was one of our big questions. So I actually started this project during my first year of residency and was able to carry it on. So that was one of the discussions that we had with our obstetrics team was just why are we getting so many of these denials? Because you saw, over 400 patients were not seen. Ultimately, it was difficult to determine exact reasons. A lot of them were just unknown why that BPA was kind of pushed to the side. There was some where a patient maybe requested that they did not want to be seen. And then one of our biggest hurdles too was just determining, if maybe the drug allergy clinic had reached out to patients to schedule an appointment and they weren't able to get on the schedule in time, or kind of if there was a lapse there a little bit. Unfortunately, we weren't able to get a lot of good answers about if the schedulers had reached out and not heard back from them. But definitely something we discussed with the obstetrics team to just make sure we know exactly kind of how the process and workflow goes on their end to make sure we're catching as many patients as possible.
Okay, great. Thank you so much. And we'll take a moment to see if there's any additional questions from the audience. All right, I think I am hearing no other questions. Just as a reminder, for those who were able to join a little bit later into the session, we do have the evaluation link that is put into the chat. So as our presenters are sharing their research with us, please feel free as we're going along to fill out the evaluation form. So thank you so much, Kayla, for your sharing research with us. We'll go ahead and move on to our third presenter. We have Christine Pan, who is a PGY2 ambulatory care pharmacy resident from the University of Illinois Chicago College of Pharmacy and University of Illinois Health. who will be sharing with us her project on utilizing transformative learning theory to enhance professional identity formation, a quantitative step.
Thank you so much. Let me just make sure I'm unmuted. Yes. Okay, so my name is Christine. Like Yvette just said, I'm a PGY2 ambulatory care resident at University of Illinois, Chicago, and I'll be talking about utilizing transformative learning theory to enhance professional identity formation. And I'd like to thank my mentor, Dr. Catherine Sawyer, who was unable to make it tonight. Well, we have no relevant financial relationships to disclose. And our learning objective is to explain how a toolkit and reflective assignments created with a transformative learning theory perspective will influence pharmacy students' professional identity formation. So just a little bit of background. First, we have Mesereau's transformative learning theory. So this is an andragogical approach developed for use in adult learners to build meaning and self-reflection. And the foundation is to expand the learner's consciousness through a disorienting dilemma that challenges their feelings and assumptions in order to build new perspectives and purpose. Then we have professional identity formation, or PIF, and this is the active process of integrating the knowledge, skills, values, and behaviors of being a proficient professional. And of course, professional identity evolves and it's affected by experiences, reflections, skills gained, and more. In past studies, transformative learning theory has been used to develop reflective activities for medical residents, and currently guided reflections using a TLT perspective have not been studied within a pharmacy school curriculum, specifically in preclinical years. And due to time, I won't be going into too much detail regarding these past studies, but you can feel free to ask me some questions after. So in the previous studies I just mentioned that looked at transformative learning theory and/or professional identity formation, two validated questionnaires have been used. One, it's called the Professional Self-Identity Questionnaire, or the PSIQ-9, and then also the McLeod-Clark Professional Identity Scale, or the MCPIS-9. So moving forward, I'll be calling the second questionnaire just the McLeod survey to make it simple. So the first one, the PSIQ-9 survey, assesses how different curricular features influence students' professional identity development, and the McLeod survey assesses how professional identity varies among health profession students and predicts variability in professional identity. And then overall, when looking at the background studies, which involve professional identity formation, using the PSIQ-9 survey showed PIF progression among medical students, and then using the McLeod survey showed no change in PIF among the pharmacy students. This is just an example of some questions that are asked, or the only questions that are asked in the PSIQ-9 questionnaire. So for example, the first question asks, when I am working with other health and social care professionals, I feel like a blank. And students can either answer not applicable, first day student pharmacist, all the way to newly licensed pharmacist. As a FYI, the original study that validated the survey had also included the answer choice not applicable. Here's a McLeod survey. So for example, first question asks, I feel like I'm a member of the pharmacy profession. And then students can answer from strongly disagree to strongly agree. And then of note, questions 3 to 5 are negatively phrased. For example, question 3 reads, I am often ashamed to admit that I'm studying for the pharmacy profession. Our study objective is to analyze how this professional identity formation toolkit created with a transformative learning theory perspective will influence pharmacy students' professional identity using these two questionnaires I just mentioned. Our hypothesis is that this toolkit will positively influence pharmacy students' professional identity formation throughout the semester. I'll go on to our methods now. Eligible participants were 79 second-year pharmacy students who were enrolled in the fall introductory pharmacy practice hospital course. They were only included, though, if they completed the toolkit and also both questionnaires during weeks 1, 8, 15 of the semester. And then before reviewing the slide, I just wanted to go over exactly what this professional identity toolkit consisted of. So in this toolkit, first, students have to read a case vignette from a real-life pharmacist example that poses a disorienting dilemma. Afterwards, students were to complete both surveys. Completing these surveys, though, was not part of the research, and it was not mandatory for students to complete, but all students did consent to take the surveys. Afterwards, students would then answer reflective prompts related to their initial responses to this disorienting case vignette. And their responses were recorded, and then each student had to listen to 2 classmate recordings and respond to them. And then lastly, they had to record their thoughts after listening to their classmates' thoughts about their reflection. So at week 1, 49 students had completed both questionnaires and also started this PIF toolkit that I just described. And then by week 8, 39 students in total had completed 2 of the PIF toolkits. There were 4 in total. 4 vignettes in total, and then they also completed both questionnaires. And then by week 15, 11 students completed all of the PIF toolkit, so 4 vignettes in total, and both questionnaires again. So for outcomes, the primary outcome is to look at the change in student pharmacist questionnaire responses from weeks 1 to 15 regarding their PIF after completing this toolkit. And secondary endpoints is looking at changes in their questionnaire responses from weeks 1 to 8, and then weeks 8 to 15. In terms of statistical tests, we use basic descriptive statistics for baseline characteristics. We also use the Wilcoxon-Simon test for both primary and secondary endpoints. For both endpoints, we also use descriptive statistics. So for each student, I looked at their questionnaire responses between weeks 1 to 8, 8 to 15, and 1 to 15, and coded them as showing development in their professional identity, stasis, or regression. Now I'll move on to the results. So 11 students completed both surveys in weeks 1, 8, and 15. And out of these 11 students, most of these were female, ages 22 to 27, Caucasian, already held a bachelor's degree, had pharmacy experience before entering pharmacy school, and are currently working in a pharmacy. For the primary outcome, looking at the PSIQ-9 survey for these 11 students, we see that in all these questions, there is 0 or a slight increase in the mean change of score from weeks 1 to 15. And as a reminder, the higher score there is, the more the student feels like a pharmacist. The only question that was statistically significant was question 9, which was about teaching others. So the mean change here was 0.64 from weeks 1 to 15. For these results, we also looked at it from a descriptive statistics perspective. And just of note, these percentages here are out of 11 students included and not the total 79 students that were eligible. So we see here for questions 2, 5, and 9, most students showed development from weeks 1 to 15. And then for the other questions, there was a majority of questions that showed PIF stasis or an equal amount of development and stasis. Looking at the primary outcome for the Micloid survey, we can see that there is actually 0 or negative change in the mean score from weeks 1 to 15. And like I said before, questions 3 through 5 are negatively phrased, but we did reverse score these. So that means here, these negative mean changes does mean a decrease in professional identity formation. And here, the only statistical significant result is question 3. So this means that students feel more ashamed of studying pharmacy in weeks 15 versus week 1. Like they feel more ashamed in week 15 versus week 1. There is no statistically significant results for either survey between weeks 1 to 8 and 8 to 15 for these 11 students. But when we look at the descriptive statistics for these 11 students for the Micloid survey, we can see that from weeks 1 to 15, most of the questions did not see a change in answers. And actually 2 of these questions, so 3 and 4, showed professional identity regression as the majority response. And then looking at secondary outcomes, we're looking at 39 students, and these 39 students are the ones who only answer the questionnaires at weeks 1 and 8. So for the PSIQ-9 survey, we can see that the statistically significant results for increase in their score from weeks 1 to 8 includes question 2, so communicating with patients, question 6, so consulting or using patient records, and also question 9, which is about teaching others. When looking at it from a descriptive standpoint, we see that most students from weeks 1 to 8 using the PSIQ-9 survey did not change their answers. And interestingly enough, 15 to 23% of the students answered not applicable for all these questions. And when we look at the Macleod survey, we can see that from weeks 1 to 8, all these 39 students mostly showed no change in their answers. Just due to time, I will also be skipping this learning assessment activity. But the main point here is that even though in these two surveys, there were some statistically significant results for professional identity progression and regression, overall, these two surveys demonstrate that the PIF toolkit showed professional identity formation stasis for all these students. So moving on to our discussion and conclusion. So overall, the student's professional identity did not statistically significantly increase after completing these toolkits that were developed with the transformative learning perspective. And overall, their professional identity remained the same before and after completing these toolkits when analyzing the data also through our descriptive lens. So really, larger sample sizes and longer duration of the study are needed to provide more conclusive results. And these results that we saw are similar to the background studies I mentioned before. So you might be wondering, why are the students showing some regression or stasis? And this could be due to the Dunning-Kruger effect, which is a phenomenon found where students who perform poorly often overestimated their performance, and students who objectively performed well often subjectively underestimated their performance. So regarding our study, the case vignettes were all created by real-life hospital-based conflicts that pharmacists have faced. And these second-year pharmacy students included in the study have only completed their community introductory experiential course so far, and they just started this hospital course. So they may have felt more confident in the beginning of the course, but as they went through the year and experienced other disorienting dilemmas inside and outside the classroom, including this professional identity toolkit, they may have realized that they don't know as much as they think or feel like they don't fit in with the profession. But as they progress through didactics and through their APPEs, we would expect that their confidence and then therefore their professional identity formation would increase over time. Some of our limitations is that only 14% of the students, so 11 out of the 79 students, answered both surveys at week 1, 8, and 15. There may have been survey fatigue at week 15, as at this time point, students were also filling out many evaluations for the professors as well. Additionally, the PSIQ-9 survey included not applicable as a response choice. We did see that as one of the results. 15 to 23% of students chose not applicable instead of another choice. The Macleod survey included questions with positive and negative statements. So if students did not read them carefully, they could have easily chosen, for example, a higher score. So that could mean, for example, that they felt like more ashamed for those negatively phrased statements. Additionally, the study does not account for confounders. As we know, a lot of times in the news nowadays, they talk about pharmacist burnout or pharmacist walkouts on the job, especially in retail pharmacy. So this may have affected students' opinions on the profession of pharmacy. This was only done for one fall semester, so it's a short duration of study, and only P2 students were included. So in the future, we can require students to complete both surveys at each time point. Additionally, we can remove the not applicable option in the PSIQ-9 survey, as well as expand this research to P1 to P4 year students and pharmacy residents to assess changes in response in these surveys over a longer period of time. And these are my references, and I wanted to acknowledge all my mentors as well as some of the UIC statisticians that helped me. And I'm open to any questions.
All right, thank you very much for your presentation. So we do not have any questions that came up in the Q&A, but again, we'll open the forum up to any of our audience members who might have direct questions they'd like to ask Christine.
Hi, Christine, this is Deanna. I wanted to thank you for your presentation. I did have a quick question though about, and maybe I missed this, but with regards to the toolkits, can you describe a little bit more what is in the toolkit, I guess, that the students get and what they have to complete? Because I noticed there was a large drop off in the number of students that like completed all 4 of the toolkits, I guess, or so if you could describe that, maybe I missed it again, but if you could just describe that a little bit more.
Oh yeah, totally. I think so. All students in this class had to complete the toolkit, which was reading a case vignette, recording the responses, listening to their classmates' responses as well. But the drop off is like the completion of surveys. So we are looking at the number of students who are completing the surveys after completing the toolkit. But I can give you examples of like what the actual toolkit and case vignette is included, if that's also what you're asking.
Well, yeah, I guess that, so was it just like a case that they had to read and then answer, like as a professional, those questions on the scoring tools that you had, or?
So for example, one of the cases could be like you're working in an care clinic and you provide a recommendation, but then the physician chooses like a newer medicine that they found from a commercial, then the provider asks you to follow up with this patient and like, what do you do and how do you feel? So that every student was required in the class to then talk about their feeling. Like, what was your initial reaction? Like, what are some alternative perspectives? And then those responses were recorded. But the optional part was then to complete these 2 questionnaires, which not everyone did. So this was repeated like 3 times during the semester.
Okay.
With a different case vignette.
Perfect. Thank you.
Yeah, no problem.
All right, and do we have any other questions from our audience members? Okay, I am hearing no other questions for Christine. And so with that, we will go ahead and move on to our last presenter. And last but not least, we have Sara Salama, who is a PGY2 ambulatory care pharmacy resident from Midwestern University, who will be sharing with us research that is focusing on factors that influence blood pressure lowering with the use of sodium glucose cotransporter 2 inhibitors in persons with type 2 diabetes.
All right. Thank you, Yvette, so much for that introduction. So we'll go ahead and get started. As she mentioned, my name is Sara. I'm the current PGY2 AmCare resident at Midwestern University. And today we'll be discussing factors that influence blood pressure lowering with the use of SGLT2 inhibitors, particularly in patients with type 2 diabetes. None of the planners of this activity have any relevant financial relationships to disclose. And hopefully our goal for today is that by the end of our discussion, we'll be able to describe patient-specific factors that influence the degree of blood pressure lowering in people taking SGLT2 inhibitors. So to begin, I'd like to provide us with just some background information on how these drugs work. So as we know, SGLT2 inhibitors work through a variety of different mechanisms. They have a role in inhibiting the reabsorption of sodium and glucose in the proximal tubule and then allowing for sodium reabsorption in the distal tubule of the kidneys. They're also involved in natriuresis and glucoseuria through the excretion of glucose, but they do have a role in osmotic diuresis, which results in blood pressure lowering through a sustained reduction in plasma volume. Clinical trials, such as some of the ones that are listed here, have showed a wide range and reduction in systolic blood pressure when observed in patients who are taking SGLT2 inhibitors, particularly with a standard deviation in one trial of about 15 millimeter of mercury reduction. And so this is really kind of what prompted our thinking and questioning in determining whether our patients would experience a similar change that was observed in clinical trials. So today we'll discuss which factors in particular influence blood pressure lowering with the use of these agents in persons with type 2 diabetes. So our study was designed as a retrospective cohort analysis within Advocate Medical Group. Patients were included in the study if they were at least 18 years or older and receiving care within the Advocate Medical Group system. They had to have a documented indication of type 2 diabetes, as well as had to have been prescribed at least one of the following SGLT2 inhibitors: empagliflozin, canagliflozin, dapagliflozin, or ertugliflozin for a duration of at least 7 days. On the contrast, patients were excluded from our study if they had no documented BMP or CMP within 1 year of inclusion or within 6 months of initiating SGLT2 inhibitor therapy. They were also excluded if they had an AKI or developed an AKI shortly after initiating therapy. Roughly 2,000 patients were identified for possible enrollment and inclusion between January 2013 and December 2019, relying primarily on a patient list generated from our former institution research study that looked at risk factors for development of AKI with these agents. As it relates to our statistical analysis, we performed a one-way ANOVA for preliminary results, as well as descriptive statistics to describe our findings. Our primary study endpoint is the mean change in systolic and diastolic blood pressure with the use of these SGLT2 inhibitor medications. And our secondary endpoint expanded upon that just further to determine the mean change in systolic and diastolic blood pressure based upon baseline systolic and diastolic blood pressure, baseline A1C, eGFR, age, self-reported race, and ADI or area deprivation index. And we'll discuss that further on the next slide. So as we had kind of discussed earlier, a different measure of social determinants of health. In this study, we looked primarily at the area deprivation index. So this is a measure that was created by the Health Resources and Service Administration and then further refined and validated. But essentially, it allows for the rankings of neighborhoods by socioeconomic disadvantage in a region of interest at both the state and national level. And it does so using either a complete address or a zip code. So the full address and zip code is required. It includes factors for the theoretical domains of income, education, employment, and housing quality. And here's a depiction of what it would look like as we enter these for our patients. So what we were able to do is leverage the full address and zip code from the electronic medical record to then produce a score of either 1 to 10 or somewhere in between. So a score of 1 reflects the least disadvantaged patient groups, where a score of 10 reflects the most disadvantaged patient groups. For our phase 1 preliminary study, 775 electronic medical records were included and reviewed for inclusion. Of those, 752 were included in the preliminary analysis, which is what we're discussing today, and 23 were excluded due to incidence of AKI. Of note, phase 2 of the study is still underway as data collection is still ongoing, and we hope to collect the remainder of the roughly 2,000 patients for enrollment in the phase 2 of the study. Some of the data collection points that we outlined are reflective here. So they include basic demographic data such as age, sex, self-reported race, GFR, and BMI. We also collected which type of SGLT2 inhibitor was initiated along with the dose. And then we looked at the baseline systolic and diastolic blood pressure, along with the consecutive diastolic and systolic blood pressures at follow-up visits 1, 2, and 3 within a 6-month period of medication initiation. We collected information on baseline antihypertensive medications, along with newly initiated antihypertensive medications during the study period, along with state and national ADI scores. So here we have outlined some of our baseline characteristics. On average, our patients in the study were about 59 years old, male and female alike, from a diverse ethnic background. The mean BMI was about 35, and the most common SGLT2 inhibitor that was used at the time was canagliflozin, with just under 5% of patients having a documented indication of heart failure along with. So now we'll take a look at our results. So here we have stratified the mean change in systolic and diastolic blood pressure based on the SGLT2 inhibitor that was used. Here we observe a 2 to 4 millimeter mercury reduction in systolic blood pressure and a 1 to 2 millimeter mercury reduction in diastolic blood pressure, although there was no statistical significance that was observed across the groups, depending on the agent of SGLT2 used. Our primary endpoint is reflective here. So we'll take a look here at the change in systolic and diastolic blood pressure based on the baseline systolic and diastolic blood pressure. So you can see here that they're stratified in groups of 10, with 10 millimeter mercury increases beginning at a systolic of less than 120 and a diastolic less than 60, all the way up to a systolic greater than 160 and diastolic greater than 100. And so what we noted here was actually pretty interesting. So we observed increases in systolic and diastolic blood pressure in patients who were normotensive or had blood pressures between 120 and 129 systolic and 60 to 69 diastolic. While conversely, we noticed more drastic reductions in both systolic and diastolic blood pressure when they were much more hypertensive. So we can see greater reductions with blood pressures greater than 160 over 100. Here we did observe both clinically and statistically meaningful results based on the stratification of baseline systolic and diastolic blood pressure. We also stratified our results based on varying A1Cs. When we look at our change in blood pressure based on A1C, we observe a 1.5 to 4 millimeter mercury reduction in systolic blood pressure and nearly a 2 millimeter mercury reduction in diastolic blood pressure when stratified based on varying A1C levels. However, we did not observe any statistical significance in this outcome. Next, we'll take a look at eGFR. So we have our eGFR verified and stratified across the top with, again, mean changes in systolic and diastolic blood pressure. Here we observed fluctuations in the systolic blood pressure and a up to 3.5 millimeter mercury reduction in diastolic blood pressure when stratified based on varying eGFRs. Again, here we did not know any statistical significance. Next, we'll take a look at age. So when stratified based on age, we observed a 1 to 4 millimeter mercury increase and decrease. So again, changes here in systolic blood pressure, while we observed a 1 to 2 millimeter mercury reduction in diastolic blood pressure with no statistical significance found across the varying age groups. When we take a look at race, we observed a 1 to 5 millimeter mercury reduction in systolic blood pressure and a 1 to 2 millimeter mercury reduction in diastolic blood pressure, with again, no statistical significance across the groups. And finally, when we take a look at our area deprivation index, we can see those stratified across the top. And remember, an area deprivation index score of 1 reflects patients who are least disadvantaged, while a score of 10 or closer to 10 reflects those who are most disadvantaged. And here we see some fluctuations as well with statistical significances in the mean change in systolic blood pressure as it reflects differences in ADI score. We did not observe any changes that were significant in the diastolic blood pressure based on the ADI score as it was classified. So in conclusion, kind of our general trends that we've noticed, we saw more blood pressure lowering that was observed in patients who had higher baseline blood pressures. And conversely, we noticed increases in blood pressure when patients had lower baseline blood pressures. And so really what that poses a question is, are these blood pressure medications or are SGLT2s smart blood pressure medications and how they act to manage blood pressure? Statistically significant differences in the mean change in systolic blood pressure were observed across ADI scores, while no statistically significant differences in the mean change in systolic and diastolic blood pressure were observed when they were stratified based on the type of SGLT2 inhibitor that was used, or the varying ranges of A1C, eGFR, age, or self-reported race at baseline. Here I've outlined just briefly some strengths and limitations of our study. So strengths are that we have a large sample size of about 700 patients now, and hopefully as we continue with phase 2 of the trial, nearly 2,000 patients. We did also include a variety of secondary endpoints, and we were able to collect on a diverse patient population. Some limitations of the study are the fact that we have not yet evaluated medication changes that may have occurred during the study. Those will be looked at more closely for the final analysis. We also don't have an assessment of medication adherence in that 6-month period of medication use. We did have some missing data based on patient follow-up. So for example, if patients presented at baseline and for visit 1 within that 6-month period, but then did not present again until month 8 or 12, we were only able to collect the first 2 blood pressure readings. And then finally, just variable documentation in the electronic medical record. So oftentimes navigating that could be provider specific. In terms of clinical application, our role as pharmacists is to continue to monitor patients on SGLT2 inhibitors for signs of volume depletion, hypotension, and changes in blood pressure, as well as assess the impact of social determinants of health as they relate to patient care and medication. Future directions of the project include completion of chart review and then potentially a regression analysis to determine predictive factors that may lower blood pressure by about a 10 millimeter mercury difference with the use of these agents. Here are my references, and I'd like to acknowledge Christy Schumacher, Dan Landup, and Charlotte Bulk for their assistance with this project. At this point, I can take any questions.
All right, and thank you very much for your presentation, Sara. So we do not have any questions from the Q&A session, but again, opening this final forum up to see if any of our audience members have questions they would like to directly ask Sara.
Hey, Sara, it's Deanna again. I did have a question for you on one of the last results you had with regards to the deprivation index, and you, if I'm not recalling looking at your results for the systolic blood pressure changes, I saw that you had that the score of 9 had like an 11 maybe millimeter or a drop or something, but then like your 10s was a very small number of change. So I don't know if you
Yeah.
discuss that at all, if it maybe there was, I just thought that was such a difference between a 9 and a 10 there.
Yeah, so you're probably referring to this difference right here.
Yes.
Yeah, so thank you for mentioning it. So we kind of hypothesize that potentially folks with a higher ADI score may require or may present with like sustained reduction, so kind of closer to this -11 versus this -0.5 over here. I'm wondering if it has to do with, one, the number of patients in each group, since these samples are still pretty small, if that may change with the results of the final conclusion and the final results of the study. Additionally, though, too, just kind of contrasting it, there's kind of fluctuations across the scores, but then hopefully what we'll be able to do too is kind of start to group some of these ADI scores together. So for example, in our final analysis, we may go ahead and group like ADI scores 8 to 10, 5 to 7, things like that, to see if that may affect our differences. So one, maybe with a larger sample size, we may be able to see more of a clear distinction, like is it really just this 9 score that shows a sustained reduction, or is it this mostly disadvantaged group altogether? So it may just be like splicing of the data in multiple ways that has showed some of these variances, but definitely something to look into for the final analysis.
Yeah, and there's a follow-up question to that. Is there any, with these actually use the ADI score and the other score as the previous resident presented on, are new to me actually. So like, are there ways, do they present them as such like very high risk or very disadvantaged in that like 8 to 10? Is there certain things where they break down the scores that way?
So yeah, not so much from what I've read, mostly just based on those factors, kind of like housing quality, employment, some of those other factors that we talked about that kind of go into presenting the score. I would have to look into it a little bit further, but I'm not sure, like if we do end up merging some of these numbers, like 8 to 10, is there really a difference between 8 and 10? Right. And, how drastic of a difference is, what would be kind of, missing or accounting for if we kind of keep them separate. So.
Okay, perfect. Thank you.
Yep.
All right, great. Do we have any other questions from any of our other audience members? Okay, and I'm hearing no additional questions at this point. And so with that, we have come to the conclusion of our resident research webinar. So I just want to say thank you all for attending and spending some time to see our residents and see how their research has progressed, and looking forward to some of the final analyses for our residents. Just as a few quick reminders before I hand it off to Deanna. We do have the evaluation form that is available. Again, it's in the chat and was also sent out in an email. So if you are able to, again, complete those evaluation forms for our residents, we will be sharing the feedback shortly with them so they can continue to take that feedback and apply it to their research projects as they continue forward with it. And this webinar is being recorded. So within the next couple of days or weeks, This is going to be published for any future reference points for those who might be interested. I'll go ahead and send off it to Diana to see if there's any last minute points that we'd like to share.
Yeah, no, I just wanted to say thank you to all of the residents that did take their time today to present. This is our first time doing this, and I think it was a wonderful event, and appreciate all your hard work that you put into the research that you have completed. And then I will just, last thing I was going to say is with regards to evaluation, I'm just going to leave that open until Friday. And then I'll collect responses and send that back to the residents at the end of this week. So if you have time to get that evaluation in, either, I know it's kind of late in the evening, so if you'd prefer to do it over the next few days, that's okay too. So those evaluations will be open until Friday. So thank you all for joining us tonight.
All right, and with that, I think we will go ahead and conclude our webinar and hope everybody has a wonderful night. And thank you again to all of our